Welcome to the deep dive. Today we're tackling, well, a really fundamental process in the human body, how blood clots form, and just as importantly, how they naturally dissolve.
Absolutely. It's this delicate balance that's just so crucial for a healthy cardiovascular system.
Yeah, think of it like the body's own rapid repair crew, but one that also cleans up after itself to keep the plumbing clear.
Exactly. And the material we're looking at today really dives into this interplay. Not just the steps for stopping bleeding, but also the medications, the drugs we use to influence these pathways.
Right. So our mission today, let's unpack the nuts and bolts of hemostasis, blood clotting, and then how the body breaks those clots down.
And crucially, how different drugs step in to help regulate things when that balance is off.
Exactly. This is really geared towards you, our listeners, in fundamental nursing programs. Understanding this stuff is, well, it's foundational for the care you'll provide.
Definitely.
Okay, let's jump right in. Hemostasis, when a blood vessel gets injured, what's the body's first move?
So hemostasis, at its core, it's the body's way of stopping blood loss.
Yeah.
Quick, coordinated. It involves basically 4 main protective mechanisms that kick in almost immediately.
Okay, mechanism 1, vasoconstriction. The vessel tightens up.
That's it. The immediate narrowing of that injured blood vessel, like pinching a hose, slows the flow right down.
Reduces the opening, minimizes the bleeding.
Right, and sometimes, for very minor injuries, that constriction might actually be enough on its own.
And our sources mention thromboxane A2 playing a part here, especially in smaller vessels.
Yes, that's a fascinating bit. The platelets, the first responders, actually help with this initial squeeze. When they get activated at the injury site, especially those tiny vessels, they release thromboxane A2.
Like a local signal flare.
Kind of, yeah. It tells the smooth muscle in the vessel wall, contract harder. A rapid, microscopic first aid right there.
Okay, vessel narrows. What's next? The platelet plug formation. How do these little guys get involved?
So when that inner vessel lining is damaged, it exposes stuff that's normally hidden, like collagen, and a protein called von Willebrand factor.
Acting like sticky patches.
Exactly like sticky patches. Platelets floating by recognize these spots, they change shape, get stickier, and bind right onto that exposed collagen and von Willebrand factor.
And then they call for backup.
Precisely. Once those first platelets stick, they release chemicals, ADP, serotonin, others. These are like recruitment signals. They attract more platelets to the scene.
And they all clump together. Aggregation.
That's the term, aggregation. They clump together, forming this initial temporary seal over the injury, the platelet plug.
The sources also mention GPIB, GAN-IA glycoproteins. What's their specific job in this sticky situation?
Yes. Those are receptor proteins right on the platelet surface. They are absolutely critical for making that aggregation strong.
Like molecular Velcro.
That's a great way to put it. They bind to von Willebrand factor, they bind to fibrinogen, which we'll get to, and importantly, they bind platelets to each other. They form the bridges that hold that plug together.
Okay, so initial vessel squeeze, then the sticky platelet patch. That's the immediate fix. What comes after that? The coagulation cascade sounds more complex.
It is definitely more involved. It's a sequence, a chain reaction, activating numerous clotting factors one after another.
Like a biological assembly line.
Pretty much. Yeah. And the ultimate goal of this whole cascade is converting a soluble protein in the blood, fibrinogen, into an insoluble form called fibrin.
Fibrin. That's
the key structural element. These long, thread-like fibrin molecules weave themselves into the platelet plug, making it much stronger and trapping blood cells. That forms the stable clot.
Got it. And it's important, our sources note, that many of these clotting factors are made in the liver and need vitamin K, and calcium is involved too.
Yes, absolutely critical points. Liver synthesis, vitamin K dependence for several key factors, and calcium ions are needed at multiple steps in the cascade. Acts like a helper, a cofactor for many of these enzymatic reactions.
Understanding that helps make sense of how some drugs work, I imagine.
Definitely. Like Warfarin, for instance, targeting that vitamin K dependence.
Right. Now, this cascade has 2 starting points mentioned, intrinsic and extrinsic pathways. How do they differ?
Okay, let's break it down. The intrinsic pathway gets triggered when blood comes into contact with something inside the damaged vessel, usually exposed collagen.
Okay.
This contact activates the first factor, Hagman factor, or factor 12. And that sets off the chain reaction. Factor 12 activates factor N, and so on down the line.
Leading eventually towards making thrombin.
Exactly. Ultimately aiming for that conversion of prothrombin to thrombin.
So intrinsic starts inside the vessel contact, What about the extrinsic pathway?
Extrinsic, as the name implies, is triggered by something outside the blood vessel itself. When tissue around the vessel is injured, those cells release a substance called tissue thromboplastin.
Tissue factor.
Right, tissue factor or thromboplastin. This substance activates different clotting factors, starting a separate, usually faster cascade, also aimed at making thrombin.
So different triggers, same goal. Do they ever meet up?
They do. They converge into what's called the common clotting pathway.
Ah, okay.
This convergence point is the activation of Stewart factor, factor X. Activated factor X is where both pathways funnel into.
So factor X is key.
Very key. Activated factor X, along with factor V, calcium, and phospholipids, forms a complex called prothrombin activator. This is the critical link.
Making factor X a target for some drugs, too.
Absolutely. The factor Z inhibitors work right there.
Okay, so this prothrombin activator complex, what does it do?
Its job is to act on prothrombin, another clotting factor, and convert it into the active enzyme, thrombin.
Thrombin. The star player sounds.
Thrombin is central, yes.
Yeah.
Its main job, the most famous one, is converting that soluble fibrinogen into the insoluble fibrin threads we talked about.
Oh, threads that form the mesh.
Exactly. Those fibrin threads weave through the platelet plug, trapping red cells, white cells, everything solidifying it into a stable blood clot, a thrombus. See how it all links together. Initial response, then the complex cascade.
That paints a really clear picture of clot formation. But like we said, the body can't just leave clots lying around forever. There's an unclotting system, too, clot resolution.
Precisely. Equally important. It's called fibrinolysis, breaking down the fibrin. This keeps vessels open, maintains patency, prevents blockages.
And the main player here is plasminogen.
Plasminogen, yes. Also called profibrinolysin. It's the inactive precursor.
Made in the liver, circulates in the blood, waiting
to be activated. To dissolve a clot, plasminogen needs to be converted into its active form, which is plasmin, or fibrinolysin, the fibrin dissolver.
What triggers that conversion turns plasminogen into the clot buster plasmin.
Several things can. Interestingly, Hageman factor, factor 12, which started the intrinsic pathway, also helps activate plasminogen, the efficient system.
Wow, double duty.
Right. Other activators include things like ADH, epinephrine, adrenaline, even fever-inducing substances called pyrogens, emotional stress, physical activity, and an enzyme called urokinase.
So once plasmin is active, what does it actually do to the clot?
Plasmin is essentially a protein-dissolving enzyme. It targets the fibrin mesh, the structural framework of the clot.
Which cuts it up.
Basically, yes. It breaks down those fibrin threads into smaller fragments, dissolving the clot's integrity, allowing blood flow to be restored.
The sources mentioned high plasmin levels in specific places like the lungs and uterus. Why there?
Good observation. In the lungs, with that huge, delicate capillary network, high plasmin helps quickly clear out any tiny clots. Microthrombi, keeping gas exchange efficient.
Makes sense. And the uterus.
Especially during menstruation or pregnancy, maintaining blood flow is critical. Plasmin helps prevent too much fibrin buildup. The example given is menstrual flow.
Ah, right. It's usually fluid, not big solid clots.
Exactly. That's plasmin at work in the uterine environment, breaking down fibrin as it forms, leading to that slower, more fluid blood loss rather than large obstructive clots.
Okay, so we have this amazing balance. Clotting to seal leaks, fibrinolysis to clear the pipes. What happens when that balance goes wrong? That leads to coagulation disorders.
Precisely. Tip the scales too far one way or the other, and you have problems. Either thromboembolic disorders, too much clotting, or hemorrhagic disorders, not enough clotting, too much bleeding risk.
Let's look at thromboembolic first. Too much clotting. What are the dangers?
Well, forming thrombi, clots, inside vessels, blocks blood flow. That leads to lack of oxygen hypoxia, anoxia downstream. If it lasts long enough, tissue can die necrosis.
And clots can travel. Emboli.
Yes, that's a major danger. A piece of a thrombus breaks off, becomes an embolus, travels through the bloodstream, and gets stuck in a smaller vessel somewhere else.
Like a pulmonary embolism or a stroke?
Exactly. Sudden, potentially very severe blockages.
What makes someone more prone to these thromboembolic problems?
Several things. Atherosclerosis, plaque buildup, damages vessel walls, makes them rough, prone to clotting. Infections, trauma can do that too.
Slow blood flow.
Definitely. Like after surgery, long flights, immobility. Also having really thick, viscous blood.
Yeah.
And then there are inherited conditions.
Like factor V Leiden.
Factor V Leiden, antiphospholipid syndrome, genetic predispositions to forming clots more easily.
Okay, the flip side, hemorrhagic disorders. Not enough clotting. The main risk is
Bleeding. Excessive, prolonged bleeding, even from minor things. The body just can't form stable clots effectively.
Examples given were hemophilia.
Right. Classic genetic lack of specific clotting factors, like factor VIII in hemophilia A.
Liver disease.
Because the liver makes so many clotting factors, severe liver disease impairs production, increases bleeding risk.
And low platelets.
Thrombocytopenia. Not enough platelets means that initial plug formation is weak or insufficient. Critical for stopping bleeding.
It really drives home how vital this balance is. Okay, let's shift to how we intervene pharmacologically. The drugs. They fall into a few main categories.
Broadly, yes. 3 main ones we'll focus on: antiplatelet agents, targeting platelets, anticoagulants hitting the clotting cascade, and thrombolytic agents, which actually break down existing clots.
And briefly, hemostatic agents, which do the opposite, promote clotting.
Right, used to control bleeding.
Let's start with antiplatelets. How do they work? What's their main goal?
Their main goal is to make platelets less sticky, less responsive. They reduce the platelet's ability to aggregate and form that initial plug.
How do they do that? Interfere with signaling?
Yeah, different drugs work in different ways. Some block thromboxane A2 production. Some block ADP receptors, stopping those recruitment signals. Others block those GPI-BID receptors, the Velcro, preventing platelets from linking together strongly.
And one, anagrelide, works differently.
Right, anagrelide actually reduces the number of platelets being produced in the bone marrow. Different approach.
Where are antiplatelets typically used? What conditions?
Widely used in cardiovascular disease. After a heart attack, for unstable angina, keeping stents open, preventing strokes, peripheral artery disease. Often used alongside thrombolytics too.
Okay. Are there general warnings, contraindications nurses need to know?
Definitely. Allergy, obviously. Active bleeding is a big one. Bleeding disorders, recent major surgery, closed head injuries, very risky.
Pregnancy and lactation.
Usually caution is advised, need to weigh risks and benefits carefully.
And some drugs have specific warnings. You mentioned anagrelide.
Yes, since it lowers platelet count, you need caution if the patient already has low platelets, thrombocytopenia, monitor counts closely.
Clopidogrel, very common. There's something about metabolism.
Yes, a boxed warning. Clopidogrel needs an enzyme, CYP2C19, in the liver to become active. Some people are poor metabolizers. They don't activate the drug well.
So it might not work as effectively for them.
Exactly. Might need a different antiplatelet agent. Genetic testing can identify these patients sometimes.
Vorpaxar also had a warning about bleeding risk.
A strong one, yes. Contraindicated if there's a history of stroke, TIA, intracranial bleeding, or active bleeding. The risk is just too high.
What about common side effects nurses should educate patients about beyond the obvious bleeding risk?
Well, bleeding is number one: easy bruising, gum bleeding, maybe nosebleeds. But also headache, dizziness, weakness can happen. GI upset, nausea, maybe a skin rash.
Aspirin specifically.
Aspirin can irritate the stomach, increase ulcer risk, and high doses can cause tinnitus, that ringing in the ears.
Drug interactions mainly increasing bleeding risk if combined with other similar drugs.
Absolutely. Combine antiplatelets with anticoagulants or even NSAIDs like ibuprofen, and the bleeding risk goes way up. Need a really thorough medication history.
Okay, moving to the next big group, anticoagulants. How are they different from antiplatelets?
They work further down the line, not on the platelets themselves, but on the coagulation. Cascades those enzyme reactions leading to fibrin. They interfere with the formation of thrombin and fibrin. Slow down clot strengthening.
We have several types. Warfarin, the older one. How does it work again?
Warfarin targets vitamin K. It stops the liver from using vitamin K effectively to make several key clotting factors. Factors 2, prothrombin, 7, IX, and X.
So it depletes those factors over time.
Exactly. It takes a few days to see the full effect as existing factors get used up. Prolongs the clotting time.
Then the newer ones, the direct oral anticoagulants, or DOACs, sometimes called NOACs, they're more targeted.
Much more targeted. Dabigatran, for example, is a direct thrombin inhibitor. It blocks thrombin itself.
The final enzyme.
Right. Then you have Rivaroxaban, Apixaban, Edoxaban, Betrixaban. These are factor ZAD inhibitors. They block factor ZAD, that key enzyme at the convergence point of the pathways.
And Betrixaban has a specific niche.
Yes. Primarily indicated for VTE prevention in hospitalized, acutely ill medical patients who are at risk.
Okay. What about heparin and the low molecular weight heparins, LMWHs?
Heparin works by boosting the activity of a natural anticoagulant called antithrombin. Antithrombin inhibits several factors, especially thrombin and factor XAN. So heparin basically supercharges our natural braking system.
And related drugs like argatroban.
Argatroban, Desiredin, bivalirudin are also direct thrombin inhibitors, often used when heparin isn't suitable, like an HIT.
Low molecular weight heparins, dalteparin and enoxaparin, how are they different from regular heparin?
They're smaller fragments. They still work via antithrombin, but have a greater effect on factor XA compared to thrombin. They tend to have more predictable effects, longer action, maybe fewer side effects. Use your dosing often.
Interesting note about anti-angiogenic properties, too.
Yeah, some research suggests they might inhibit new blood vessel formation, but that's more an area of ongoing study.
And briefly, antithrombin itself and protein C concentrate and fondaparinux.
Antithrombin and protein C are replacement therapies for people born deficient in these natural anticoagulants. Fondaparinux is a synthetic drug that only inhibits factors A, very specific.
Okay, contraindications and precautions for anticoagulants generally. Similar concerns about bleeding.
Very similar. Allergy, active bleeding, high-risk conditions like hemorrhagic disorders, recent trauma or surgery, spinal puncture.
That boxed warning about spinal epidural hematomas with some DOACs and neuraxial anesthesia.
Yes, very important. Also, GI ulcers, recent surgery, IUDs, TB, indwelling catheters, threatened abortion. Warfarin is generally a no-go in pregnancy, with rare exceptions.
Caution with kidney or liver disease.
Definitely affects drug clearance. And heparin-induced thrombocytopenia, HIT, is a specific serious risk with heparin products.
And the main adverse effect across the board is?
Bleeding, always bleeding.
Yeah.
From minor gum bleeding to major hemorrhage, constant vigilance and assessment are key.
Drug interactions must be huge, especially with warfarin.
Absolutely massive. Warfarin interacts with so many drugs and foods because of the vitamin K mechanism. But the DOACs have interactions too.
Like with antifungals, certain antibiotics, antivirals.
Right. And drugs like phenytoin, rifampin, P-glycoprotein inhibitors with Rivaroxaban. You have to check interactions thoroughly for all anticoagulants. It's critical.
Okay, third category. Thrombolytics. The clot busters. How do they work?
They activate the body's own dissolving system. They are tissue plasminogen activators, TPAs, Alteplase, Rivaroxaban, They convert plasminogen into active plasmin.
And plasmin breaks down the fibrin mesh.
Exactly. But they only work if there's enough plasminogen around to activate. They don't work if the body's supply is depleted.
When are these used?
Critical situations.
Yes, emergencies. Acute heart attack, acute ischemic stroke within a specific time window, massive pulmonary embolism, sometimes to clear blocked central lines. Goal is rapid reperfusion.
Given they dissolve existing clots, the contraindications must be heavily focused on bleeding risk.
Extremely so. Recent surgery, active internal bleeding, stroke within 3 months, unless it's the current acute stroke, aneurysm, recent delivery or biopsy, serious GI bleed, major trauma, known clotting defects, uncontrolled hypertension, severe liver disease. The list is long.
Pregnancy lactation.
High risk, benefit must clearly outweigh risk.
Main adverse effects to watch for. Bleeding is number one.
Absolutely. Intracranial hemorrhage is the most feared complication. Monitor hemoglobin, hematocrit closely. Also, reperfusion arrhythmias can occur when blood flow returns to damaged heart tissue.
Hypotension. Mental status changes.
Yes, all possible. GI bleeding, hypersensitivity reactions too. These are powerful drugs requiring intensive monitoring.
And interactions. Combining with anticoagulants or antiplatelets dramatically increases hemorrhage risk. Usually avoided or managed extremely carefully.
Okay, last category briefly. Drugs to control bleeding. Antihemophilic agents and hemostatic agents.
Antihemophilic agents are replacement factors for people with hemophilia. Factor VIII concentrate for hemophilia A, factor IX for hemophilia B, etc. Dosing is very specific.
And hemostatic agents. Stopping bleeding more generally, systemic and topical.
Right. Systemic example is aminocaproic acid. It inhibits plasminogen activation, basically stops clots from being broken down too quickly. Used in hyperfibrinolysis states or to prevent rebleeding, like after subarachnoid hemorrhage.
Topical ones, applied right at the bleeding site.
Yes, things like absorbable gelatin sponges, fibrin sealants, glue, microfibrillar collagen, and thrombin itself applied directly to help form a clot locally.
Including recombinant thrombin to reduce allergy risk.
Exactly. Avoids potential reactions to older bovine-derived thrombin.
Wow. We've covered a huge amount today, the whole process, clot formation, dissolution, the disorders, and then all these different drug classes influencing it.
It's a lot, but it's so interconnected. Antiplatelets, anticoagulants, thrombolytics, each hitting a different part of the process.
And it underscores how critical understanding these mechanisms, indications, contraindications, side effects really is for nursing practice.
Absolutely. And remembering hemostasis is dynamic, these aren't static situations. Monitoring, assessment, patient education, they're paramount. Understanding the why behind checking for bruising or monitoring PTT or INR or teaching about dietary interactions.
That leads perfectly to our final thought for our listeners. Thinking about this delicate coagulation balance, where are the really critical areas where patient education can make the biggest difference in using these meds safely and effectively?
Oh, that's such a key question for practice.
Especially considering diverse populations, lifespan issues, all those potential interactions we discussed.
I mean, teaching patients to recognize signs of bleeding and signs of new clots is huge. Emphasizing why adherence is so vital. Explaining potential interactions, not just drugs, but OTCs, herbals, even foods like leafy greens with warfarin.
And the importance of follow-up labs and appointments.
Absolutely. Empowering patients with that knowledge helps them become active partners in their own safety. It can genuinely prevent serious complications and improve outcomes with these powerful but potentially risky medications.
A crucial role for nurses, definitely. Well, thank you for taking this deep dive with us into coagulation and the drugs that affect it. We hope this has given you, our fundamental nursing students, a solid foundation.
It's essential knowledge to build upon.
Indeed. Until our next exploration on the deep dive, stay curious and keep learning.